I don't know. She had to drive to this place.
That's who they
Yeah.
No, I have.
So, the word of the day for CME credit is Stony Brook. I thank Dan for getting the broadcast to work today. Drew's away. Here's the man I was waiting for. I was just about to say we didn't have any handouts for those in the room, and Frank has them. For those on the outside, I don't think we sent out the usual PowerPoint yesterday ahead of time. I can have that done later if you save them, but hopefully you've got a good broadcast you're watching now, and the actual presentation will be recorded. So Thao's going to talk today about asthma, COPD, overlap syndrome.
Good morning, everyone.
Speak loudly.
All right, so Len asked me to talk about this topic, which is the asthma COPD overlap syndrome. And it's an interesting, somewhat controversial syndrome. Now, the big question is, should we use it as a tool, or should we still consider asthma and COPD as two divergent conditions that can be seen in the same patient? I have no disclosure. But yeah, so objectives for today, we're going to review, since we're going to talk about the overlap of the two diseases, we'll review the features of asthma and the features of COPD first, and then we'll describe asthma COPD overlap syndrome, or the current description of it. We'll also review some of the literatures on the overlap phenotypes that can be seen in asthma and COPD. And then finally discuss the role of why defining this overlap syndrome may have an impact on future therapeutic approaches for this patient population. And so just a quick reminder that asthma and COPD, taken as a whole, affects about 1 out of 12 people worldwide. It's, both conditions are considered chronic conditions that has a huge health cost impact. And so asthma, as we already know, these are our patients, but specifically defined in their very characterized population. It's a heterogeneous group of diseases characterized by chronic inflammation of both the large and the small airway. We see it typically develop in childhood, but there are adult presentations of it. It's often associated with allergic and atopic diseases, though we do have defined adult asthmatic that often have non-atopic diseases. Classically, these are what we used to characterize as intrinsic asthma with aspirin sensitivities, nasal polyposis. Definitely, they still have the characteristic of high eosinophils in sputums, high eosinophils as inflammatory markers in their lungs, and responding to high-dose corticosteroid. Again, asthma is a variable expiratory airflow limitation, and most of these patients, their airflow limitation reverts completely back after an attack. And this is a result of smooth muscle bronchospasm more so than airway mucus production and inflammatory infiltrate. And the pathogenic characteristic of it is eosinic inflammation in Th2 lymphocytes. In contrast, our chronic obstructive pulmonary disease patient that is considered a preventable inflammatory disease of the small airway, and they can be characterized in two subgroups: those with more features of chronic bronchitis, which mainly has inflammatory infiltrate of the airway, and those with the emphysematous feature, where the clusters of inflammation is near areas of alveolar tissue breakdown. Their symptoms with COPD often is an adult presentation after 40 years of age, and it's associated with classically smoking, but it's definitely a response to noxious particles and gases. Smoking history, more so than passive smoking history, air pollution, but it's seen in occupational exposure also. And COPD is considered a persistent and progressive airflow limitation disease. It's a result of smooth muscle contraction again, airway mucus secretion, tissue breakdown, and then a specific loss of elastic recoil and airway closure. And their pathogenic features is more of a neutrophilic inflammation and more of a CD8 lymphocyte. But in our clinical setting, in our practice, we've seen patients with features of both. We've seen the asthmatic with partial reversibility. We've seen the asthmatic with bronchiectasis and emphysematous change. We've seen our complicated asthmatic with asthma who progressed to more of a COPD feature. And while our therapies and our therapeutic paradigm, based on randomized control study, really does look at treatment paradigms for asthmatic condition as a population and COPD condition as a population separately, we don't have a lot of randomized control study looking for the therapeutic management of patient with both features, as their lead presentation. So the question of what to do with that population, and sorry for the autocorrect, I think it's supposed to read asthma and COPD overlap syndrome rather than cold syndrome. But asthma and COPD overlap syndrome. This was something that was really pushed out by the Global Initiative of Asthma and the Global Initiative of Chronic Obstructive Lung Disease. And they wanted to describe this population as those characterized by persistent airflow limitation, which is seen in both, but with several features of asthma and several features associated with COPD. As you can see, this kind of characterization or definition by Gina and Gold is very vague, it's very loose, but it wants to actually initiate this look into this unique population. And this concept is not new. It was actually proposed in 1961 by Professor Ori and his colleague, as we know now as the Dutch hypothesis. And they feel that this whole chronic, undefined lung disease of asthma and bronchitis actually is probably the same disease with shared clinical expression. And the specific expression, the specific phenotype of these different populations are determined by their endogenous feature, the genetics, the age, the sex, provoked also by the environmental factors, giving them more of an asthma presentation, COPD presentation, more of an overlap presentation. So when we're looking at patients who we want to consider asthma, COPD, overlap syndrome, there's no specific definition yet. There's this loose categorization, and consequently, there's a huge group of population that can fall based on their clinical history. And as mentioned previously, it could be our asthmatic with significant smoking history, where as a population we've seen asthmatic with no smoking history, they tend to actually have more of COPD features as they get older, and their features are often actually worse than COPD patient alone, those without asthma. These can be our patients also who have no significant smoking history, but they do have childhood asthma with these persistent airflow limitation that we keep on seeing progress through adulthood. There's reversibility, but also progression of their disease process. And then there are patients who presents with severe asthma and progressive asthma, and they've always seemed to have incompletely reversible airflow limitation. And their presentation doesn't have to drag on through childhood, but they can have acute, severe, rapid presentation, though they still have the variable reversibility of a classic asthmatic. And then, of course, instead of looking from an asthma progressing to COPD presentation, there are some patients who are no smoker with features of COPD, but in their evaluation, we actually see variable airflow limitation, and the family or personal history of asthma and allergy. And then, of course, our consultation from our pulmonary colleague who sent us their emphysematous patient, but they have these very severe allergic presentation and obvious bronchodilator reversibility on exam. So all these this population of patient can fall under this syndrome. This is just from the New England Journal of Medicine, and this is just I thought it was a nice graphic of the general difference in the FEV1 and age progression, but similarities of ACOS in this model. You can see in COPD, which is an attack and inflammation of the small airway, a lot of COPD patients can, even in their 20s, present with lower lung function. And when they have exacerbation, you can see a fall in FEV1, but they often have this presentation of gradual improvement rather than rapid improvement of their FEV1. But over time, there's a general loss of their lung function. And on the right-hand side, you can see the more severe asthmatic presentation. They may have normal lung function at the beginning, early in their age, but when they do have exacerbation, their FEV1 falls rapidly, but they also have a rapid recovery. In those patients, I don't know if I could pull up a mouse here, but in those patients with a mild asthmatic presentation, there is just usually not a rapid or general loss. There it is. Yeah. So in mild asthma, there's usually not a general rapid loss of FEV1. So they can have exacerbation, but they would regain a lot of their lung function. But this is a modeling of more of a severe asthmatic presentation that can lead to more of an asthmatic COPD overlap syndrome. But they would have frequent exacerbation, loss in FEV1, rapid return, but a poor full reversibility and a general decline of their lung capacity over time. And then in both populations, those whose asthma, COPD, obstructive disease presentation, as well as stemming from COPD and those stemming from asthma, they often actually have a late presentation, lower FEV1 function, and they are generally difficult to distinguish from each other because they often actually have very frequent and severe exacerbation and a significant decline in lung function loss. So prevalence, with such varying definition out there, because there's no, defined way of describing ACOS. Some people feel that it's asthma with partial reversibility, so they use spirometry data. Some people use syndromic paradigms for this. Instead of patients with wheezing and chest tightness, as the classic asthmatic, these are patients with wheezing, chest tightness, dyspnea, chronic cough, high sputum production. They would plant them into this whole asthma, COPD overlap syndrome. So with that flexibility, when you look at prevalence data for these patients, it's actually quite a huge range. But in patient self-report survey, 15 to 20% of patients with reported diagnosis of both asthma and COPD. In Marsh et al. Group of studies, they looked at patients with COPD in a random population-based study of adults greater than 50, and 55 of them, based on questionnaires, pulmonary function tests, and high-resolution CT, would have actually asthma characteristics. So that's more than half of their greater than 50 years old patient population. Then there was a huge +1 meta-analysis study of 19 asthma COPD population, a hospital-based study, and they had a pool prevalence of 27% with a range of 15 to 55%. And so you can see from most of the meta-analysis out there for the prevalence of ACOS, it ranges from 50 to 55 in general. What I thought was a more important aspect was summarized by Redder and Jackie in 2015. What they mentioned is that in most therapeutic clinical trials, both the concomitant diagnosis of asthma and COPD are exclusionary criteria. So the median our respective trial for asthma and our respective trial for COPD. That just mentioned that that whole pot of population that's being ignored probably have some features of both. And our therapeutic paradigm don't address that population.
Does that last point mean only 4 or 5% are pure COPD or pure asthma, and everybody else is in between?
By Derek, yeah. So,
Doesn't seem right.
Yeah.
It seems more that you can define more than 5% of people with pretty clear-cut atopic asthma.
So, characteristics of the overlap syndrome. This was well summarized in the meta-analysis of PLOS ONE. 17 studies, 12 of them are cross-sectional, 5 are cohort study, and they reported different features, but most of them have incidence, prevalence, healthcare utilization, morbidity, mortality, and of both asthma and COPD. And it's interesting, all studies report that patients with features of both are often younger than COPD alone. Patients with asthma, COPD, overlap syndrome often have more frequent exacerbation, more hospitalization, and more emergency room visit compared to COPD. So they're younger, and they often have a poor presentation. And then 2 out of the 3 studies shows that the medical care cost of these patients is 60% higher than COPD, 5 times higher than patients with asthma. 2 of these studies have shown that, interestingly, and this can be seen in a lot of studies with smokers, asthmatic who are smokers, they often have a higher BMI. And but more interestingly, they also in general have a lower pack-year smoking history than COPD alone, suggesting that asthma is a risk factor for smokers, leading to much more severe COPD presentation. And then in general, there's no gender difference or difference in pulmonary function tests. This is a busy slide that was mainly to refer you to the therapeutic advances in respiratory disease, which is another good summary of the varying studies out there addressing asthma, COPD, overlap syndrome. But again, it's just to sort of generalize the clinical feature finding that's very similar to other studies, that these patients have more symptom presentation of wheezing, dyspnea, sputum production that can be seen in both diseases. They generally have a poor, in comparison to COPD, a poor health-related quality of life level. They often have more exacerbation. And more interestingly is that the inflammation in this subpopulation, those have higher sputum neutrophils, more so than the asthmatic. And then they also have a higher sputum eosinophil presentation than COPD. And so it suggests that this population do ride the middle feature of both disease from a pathogenesis pathway also. This also mentioned that in general they have a higher morbidity and mortality than asthma and COPD alone. Imaging studies are very limited in this group of patients. Those with asthma, COPD, overlap syndrome have variable evidence of emphysema on high-resolution chest CT, and then they also have less evidence of emphysema in general in comparison to a COPD patient alone. But more interesting, they also have more of an upper lobe predominant emphysema than COPD. So, in general, those are the literature that's trying to characterize this asthma, COPD, overlap syndrome. But over the years, we've actually seen literature looking at patients in asthmatic patient and COPD patient, and we've seen over the years phenotypic overlap that occurs in our study. So, as a quick summary, if you're looking at total IgE or atopic presentation, just just a quick reminder, healthy subject, we have IgE increases with age until our mid-30, and then it decreases. 50% of young adults in the U.S. have increased total and specific IgE levels, which may be clinically insignificant or clinically relevant. IgE is often associated with specific allergy, and IgE increase is also associated with smoking. Now, when we look at a COPD population, the prevalence of atopic disease is about 18 to 30%. And this patient, when you look as a whole, often are younger, tend to have a male prevalence and a higher BMI. It's interesting that there's no evidence that an increased IgE level is associated with decreased lung function in asthmatic or non-asthmatic children in the CAMP study. Risk factor for elevated IgE level is not considered a risk factor for development of COPD, and increased IgE level does not protect the clinical course severity of COPD. But elevated IgE level is a predictor in multiple studies of a good response to inhaled corticosteroid in adults with asthma and COPD. So,
now, did you come across any association with severe eczema and filaggrin mutation?
no.
In this group? Curious.
But definitely sure they're going to look for that. So,
One thing you said I didn't know. Anybody else know that IgE goes up in smokers?
It was on the boards back in '82.
That's right.
It was. It was on the boards back there.
Is it true?
The only
Yes.
question we got right.
It was '85, actually. We took it in '85. You taught me that.
I did. I never knew it. Or I knew it and forgot it.
when we look at eosinophilic inflammation, again, this is one of the. Did I see that? This is a classic feature of asthma. It's activated by IgE and non-IgE pathway when we describe the cellular physiology. The non-IgE Th2 pathway has been defined over the past few years, but there are certain cell lines that are involved with it. Type 2 innate lymphoid cells, IL-33 is associated with it. Elevated GAD3 is associated with it. Eosinophilic inflammation are most prominent in asthma patients, and it's often associated with exacerbation, severity of symptoms. The higher the eosinophilic inflammation, the often more severe the airflow obstruction and bronchial hyperresponsiveness. And it's also a marker in which is associated with improvement of FEV1 if given inhaled corticosteroid. And so elevated sputum eosinophils are found, however, in 15 to 40% of patients with COPD. It again is also associated with frequency of exacerbation. It's associated with the severity of airflow obstruction, and it's also in the COPD population associated with the response to inhaled corticosteroid when compared to their non-eosinophilic counterpart. So this pulls away that COPD population that has a different therapeutic paradigm than their classic COPD population. It's interesting, in a COPD gene cohort study, it's a big study by Harden, there's evidence that a single nucleotide polymorphism, the GPR65 gene, was actually associated with patients with presentation of both COPD and asthma, both in smokers and non-smokers. So GPR65 is a member of the G2A gene protein couple family. Please don't ask me data on that. But it plays a role in eosinophil activation. So again, this is a gene study that actually pulls away a very unique subset of the COPD population. And then in the ECLIPSE study, the evaluation of COPD longitudinally to identify predictive surrogate endpoints 87.4% of COPD patients had elevated both peripheral elevated peripheral blood eosinophils. Now, this is not dramatic elevation of blood eosinophil. This is low but different elevation compared to those with COPD without elevation. They compared the two populations, and there is a unique distinction with that population. Again, they highly responded to high-dose inhaled corticosteroid treatment. They tended to be older males with lower BMI, though, so these are those with a blood eosinophilia. And as a population, they actually had fewer symptom exacerbation compared to their COPD cohort. When we look at neutrophilic inflammation, this is our classic marker of COPD and smoker. But elevated, as we know, elevated sputum neutrophils can be seen in asthmatic. It's often in severe asthma with fixed airflow obstruction, and often asthma with smokers. And they often require a high dose of inhaled corticosteroid. It's also interesting in a number of asthma study out there, those with mild to moderate asthma, the patients who are on moderate dosing of inhaled corticosteroid also happen, and this is without COPD feature, also happen to have a more of a neutrophilic inflammatory sputum. So, also looking at bronchial hyperresponsiveness, this is the variable component due to acute release of pro-inflammatory mediators. There's fixed structural components to bronchial hyperresponsiveness. There's epithelial desquamation, goblet cell metaplasia, fibrosis, loss of elastic recoil, smooth muscle hypertrophy, angiogenesis, matrix changes. So those are the features of BHR. It's a hallmark of asthma associated with airway inflammation, usually due to eosinophils and mast cells, and it's associated with exacerbation and morbidity. But this bronchial hyperresponsiveness can be found in 60% of the patients with COPD, and often associated with risk factor for accelerated reduction in lung function in COPD, especially in active smoker, higher residual volume air trapping, and it's associated with actually increased mortality in COPD patients. Finally, reversibility. This is how we define our asthmatic in our clinic most of the time. As reversibility can be demonstrated both large and small airways. There is generally a diminished reversibility seen in our more moderate to severe asthma patient. But 20 to 50% of COPD patients can have significant reversibility at some times in their disease progression. And actually, a number of small studies have shown that those with COPD early presentation, if you give them high-dose inhaled corticosteroid, you can actually promote more evidence of reversibility in such patients. The reversibility is demonstrated mainly in the large airway, and it's often, interestingly, not associated with prognosis, adjusted over time. And then finally, bacterial infection. As we know in our COPD patient, bacterial infection, chronic colonization, as well as infection itself is often associated with features of COPD, from bronchiectasis to recurrent exacerbation. They often actually respond to more of a chronic antibacterial therapy. But looking at asthmatic and normal patient, there's a long history of presumption that the lower airway of such patient are actually sterile or a few bacteria. But nowadays, looking at using evaluation with bronchopulmonary swabbing, there's evidence that the lower airway has a chronic colonization of microbiomes, in all patients. But it's interesting that the distribution of phyla and genera of the microbiomes in such patients are very different in those with COPD and asthma versus our see in patients with COPD and asthma, the microbiome colonization for Haemophilus is much more similar to each other than normal patient population. So the unique microbiome colonization in the small airway of these patients, it becomes a question: is it a indication of the disease progress, or is actually an indication of actually our therapy that we give them? And then, though there's evidence of overlap in multiple features of both diseases, genetics, however, actually is currently separating the two diseases because there is no evidence of any shared genetic origin in large-scale genome-wide association studies. And so what puts them together, the data can also continue to pull them apart. The question are these two diseases, two conditions that are separate in phenotype that we can see as an overlap disease or concurrent disease in the same patient, or do they, one acts like asthma acts as a risk factor for a subtype of COPD? So I think this is generally a good schematic of what is considered this whole overlap, is that they are heterogeneous diseases with groupings of unique features, on both sides. And then of their patient population, there is overlap that can be seen. And the big question is specifically defining these small subset of groups of patients. Can we define them by their phenotype, and can we actually draw out a better therapeutic paradigm for such population in future study? So talking about, how much time do I have?
About
an hour.
So talking about this population, there is, and treatment. Treatment approach for asthma and COPD are classically this way. For asthmatic, the first line of treatment has been shown to be inhaled corticosteroid with or without leukotriene. Second line of treatment is possibly adding a long-acting beta agonist. For exacerbation, we add short-acting beta agonist, or we increase inhaled corticosteroid. In our COPD population, studies have shown that their first line of treatment should be the long-acting beta agonist or long-acting anti-muscarinic. Second line of treatment is to actually add moderate to high dose inhaled corticosteroid if their forced expiratory volume is less than 50%, and they have a history of multiple exacerbation. And at this time, you can also add on the long-acting anti-muscarinic. For their exacerbation, it's short-acting beta agonists can be helpful, but majority of time, you have to treat them with antibiotic or oral corticosteroid. So that addresses the asthma population and specifically the COPD population. But Gina and Gold, in their hope to sort of pull out and define the group of overlap syndrome, they have a recommended approach of how to recognize this overlap group and actually initiate their treatment recommendation. So first, step one is to note that these patients have symptoms suggestive of chronic airway disease, and step two is to evaluate the syndromic diagnosis in these adult patients. According to them, if these patients have 3 or more features of either asthma or COPD, you should consider them to have overlap syndrome. Our next slide will review some of these features that they recommend, and of course, analyze them by spirometry. And if they do fall into this grouping of asthma, COPD overlap, the initial treatment that should be considered is actually inhaled corticosteroid and a long-acting beta agonist or an anti-muscarinic. So this is the Gina and Gold paradigm or suggestion of what we should consider as features of asthma versus COPD. And if they have 3 or more, they should have consideration that they fall into the ACOS population. But asthmatic, they're usually early onset of presentation, COPD, later onset of presentation. Patterns of symptoms in asthmatic, they vary over time, minutes, hours, or day. They have this diurnal presentation, being worse at night and early morning versus the day. And they could be triggered by a multitude of triggers out there. Versus COPD, they often have these persistent symptoms despite the treatment. They have daily symptoms with features of exacerbation in between, and they have more of this exertional dyspnea, chronic cough, sputum presentation rather than wheezing. And it can be unrelated to any specific trigger. Lung function in asthmatic, it's variable versus lung function in COPD. They show more of a persistent airflow limitation. The patients with asthma often are normal in between symptom exacerbation. The patient with COPD are abnormal. There is a patient family history of atopy in the asthmatic versus there is a previous diagnosis of bronchitis or emphysema or heavy smoking in COPD. Time courses are different in asthmatic. There's no worsening of symptoms over time. There's a variation of symptoms seasonally for those with atopy, and they often can improve spontaneously or with therapy with bronchodilators and inhaled corticosteroid, while the time course for COPD, they gradually get worse. And chest x-ray in asthmatic is usually normal versus chest x-ray in COPD shows severe hyperinflation. So this is a general gestalt of GINA and GOLD. And so consequently, the idea is if they have any of the three features in one and 3+ features in another, that's the consideration. Because there's limited data, the initiative calls for more randomized control studies to assess the efficacy of the pharmacotherapeutic, but currently their recommendation is that they feel this subpopulation do benefit from inhaled corticosteroid treatment. What is interesting, however, Dr. Lim and his colleagues published in Annals of Allergy and Asthma in Immunology a 12-year retrospective cohort study, and they compared 90 patients with ACOS feature, and they put them in the inhaled corticosteroid treatment group and the non-inhaled corticosteroid treatment group. And that recommendation did not pan out because they didn't seem to have any decrease in severe exacerbation or improvement in overall mortality. So again, there is a strong call for further evidence of what to do for this population. One of the things that evaluation of this study and a few other smaller studies out there is if we put this population with all their varying phenotypes in it, because it's a big population, will we end up, because of the non-specific phenotype, will we end up just having a lot of negative treatment results? Because a lot of treatments out there are specific to very specific pathophysiology changes. So the current, this is in Jackie, recommended therapeutic approach to studies nowadays is to look at airway, just chronic obstructive airway disease with asthma or without asthma, with COPD or without COPD, or with both feature, but to really describe this population as having either more of a Th2 eosinophilic feature or a low Th2 feature with more neutrophilic presentation or pauci granulocytic presentation. And there's a general recommendation of the different therapeutic paradigm that they can fall under. So those with more of eosinophilic feature, will go, and benefit from the anti-eosinophilic therapies out there. And our classic, as we know, is this is our asthma presentation patient. It's the inhaled corticosteroid, the anti-IgE therapy, the anti-IL-5 therapy. But then you can divide this subpopulation into even smaller group. For example, the inhaled corticosteroid is a treatment, as we know, for our asthmatic. But our asthmatic smoker, with their phenotypic presentation of more of small airway inflammation involvement, there's a number of studies showing that they respond to inhaled corticosteroid treatment that directly addresses that issue. And so they do, in general, do better with more of the ultrafine inhaled corticosteroid treatment, the higher dose ultrafine, such as the HFA budesonide study. They also do better with inhaled corticosteroid with a long-acting beta agonist therapy. And so you can really divide these treatments into smaller subpopulation with these eosinophilic presentation. Anti-IL-5 is interesting. It's been shown to be effective in reducing exacerbation at this time for severe asthma with elevated sputum eosinophils. Its role in eosinophilic COPD patient is still out there. We don't know if mepolizumab or reslizumab will have a beneficial role. There is an anti-IL-5, benralizumab, that was studied in a phase 2 study trial that showed that it did not reduce exacerbation or improve symptoms in eosinophilic COPD patient. Future studies out there, we won't go into the details of it, are anti-IL-13 studies, the GATA-3 inhibitor studies, and blocking antibody studies with thymic stromal weighted cytokines. So, anti-neutrophilic study, there is currently a lack of, but our patients with these neutrophilic presentation are more classically our COPD population. And the current therapy is really macrolide antibiotics therapy for mycoplasma pneumonia and chlamydia pneumonia. And it's been shown to be effective in reducing exacerbation in severe COPD, but it also seemed to be associated with reduction in exacerbation in severe asthma. But it's a mixed result in data with pure severe asthma alone. And then future studies in anti-neutrophilic would be studies that uses CXCR2 antagonists. These are a receptor antagonists for chemokines that are highly expressed both in COPD, in severe asthma, and in smoking asthma patients. So they have the neutrophilic features, and if we're able to antagonize the receptor, will the neutrophilic feature decrease in this subpopulation? And currently, there is the studies that are looking at some of these antagonists in early phase studies in COPD patients fail to show any significant reduction in drop in FEV1 or the reduction in exacerbation, however. So then there's other anti-inflammatories out there that's been studied. The anti-TNF has not been successful in both COPD and severe asthma. The anti-IL-1 has not been successful in COPD, and the anti-IL-17, which is expressed in sputum of severe COPD and asthma, did not improve asthma control in the brodalumab study. And then there's the molecule, the phosphodiesterase 4 inhibitors. There's limited studies that show limited response in a number of COPD patients, but there's no significant data coming out of that at this time.
On the anti-neutrophil approach, John Fahey at UCSF, he's got some recent data. He's been promoting IL-6 in this as a biomarker in this group.
Yeah.
And they've got, it's interesting, it was primarily females and really high BMIs. They were like in the mid-30s.
Right. Yeah, there's a number of them out there looking at asthmatic with severe COPD feature in especially high BMI African American women. huge severe neutrophilic feature, and it seems like that whole anti-inflammatory paradigm may be something that addresses that population. But, yeah.
So there's actually a couple of monoclonals against that now, up to IL-6 and also the receptors. Could be some future therapeutic approach that way.
And then this group called the polygranulocytic group, they don't have the high eosinophil or the neutrophilic feature, but they have the significant eosinophil COPD feature. The recommended therapy for this group is long-acting beta agonists, long-acting antimuscarinics that reduces the cholinergic tone and relaxes the airway smooth muscle. In those with asthma with this feature, long-acting beta agonists and antimuscarinic have been shown to be useful. And beta agonists in general, it does have features that appears to have functional antagonist mechanism against mast cell-derived mediators. Antimuscarinic and severe asthmatics also seem to improve symptoms, and there is a small reduction in asthma exacerbation in some studies, but overall no improvement of control in this population. In COPD, there's more data of the combination therapy of long-acting beta agonists and antimuscarinic, which does show that in this patient population, in pure COPD, there is a greater bronchodilation effect when used in combination. They have improved symptoms, and they do have generally a reduction in their exacerbation. And a lot of the description of asthma, COPD, overlap syndrome patient fall into this polygranulocytic group with some eosinophilic feature and some neutrophilic feature. So the big question for them is, are they the group that you do the triple therapy? Throw everything in the kitchen sink. Are they your inhaled corticosteroid, long-acting beta agonist, long-acting antimuscarinic therapy? So that is the rundown of this syndrome.
This is not a criticism of you, but of the field. I don't find this helpful. And the thing that I find most confusing is, we have certain rules. Don't give asthmatics long-acting beta agonists alone without a corticosteroid, and yet for COPD, that's perfectly fine. And I'm not. A lot of work has been put into this, and I'm not particularly sure they've really defined a syndrome here and differences in how to treat it with enough clarity that there's any take-home message from day-to-day practice.
I think if there is a take-home message, that's the frustration. I mean, the frustration is if we pretend that we have this very unique, distinct group of asthma, very unique, distinct group of COPD only, and we do our treatment paradigm through those, we can, and they do exist, but they address such a small subpopulation, and it's as you say, our failure to address this bigger, mixed group. And right now, I think I hope the whole initiative of both Gina and Gold is to say we need to figure out if we can more specifically describe that gray mass. And we now have the tool, unlike the days when the Dutch hypothesis came out, we do have the tools nowadays to define that gray mass more specifically. It may not be our job at this time to put them in specific category, but at least when we look at that population, we should identify them in more detail, rather than looking at spirometry data alone. In our studies, we probably should look at varying spirometry data. We should look at their biomarkers. Do they have biomarkers all over the place? Do they have more of biomarkers in one more of a Th2 paradigm, more of a Th1 paradigm? And then based on that, throw on a concept of therapy and then actually see their response. With the results of that, maybe we could actually more specifically define subgroups out there. Because having false titles is what's probably confusing us, you know, and that it's really the subgroup phenotype and the specific treatment for them that may be the future. Yeah. But,
Well, it's hard to argue that
Yeah.
having better definitions wouldn't help, but right now the state of the art, in spite of the fact people put a lot into it, is still very confusing.
oh yeah.
It doesn't seem to help in day-to-day practice when you're dealing with a patient
Right.
and choosing therapy.
Yeah. But I also agree. I mean, you know, in our patients who come in and they have asthmatic and COPD feature, you know, who tells you I don't respond to, you know, flow at 440 microgram, twice a day. Do you drop that and put on a long-acting beta agonist?
Most of us, you know, who are allergists, trained to, wouldn't take away the steroid.
Yeah.
You just say we don't think it's safe to use a long-acting beta agonist by itself, so combine them.
Right.
And leave it at that.
Right.
Yeah. Anybody else find this helpful?
Let's hear from you, the topic.
I think we have to review the topic. People are putting. I mean, Andrew did a paper on this a few months ago in journals. One of the papers you mentioned, and it's not, neither of you are at fault. It's just a very confusing field that isn't helping me anyway, any day-to-day practice of treating people.
Well, I think we're in a diagnostic hole right now. We're using 30-year-old definitions to define diseases now that are going to be much more separated out. And back then, you didn't really need to separate it out because you had 3 drugs. Now we're going to have 20, 30 different biological agents in the next 10 to 15 years. And we better know what we're doing if we're going to embark on a $10,000 a month treatment plan. And I think that's going to come. That will come. So we'll be able to define this a little bit better. Because I don't think there's going to be 3. I don't think it's going to be asthma, COPD, and crossover. I think there's probably going to be like 6 different phenotypes with different profiles, and we're going to target it in very specific ways. But we're not there yet.
I mean,
Any other questions or comments?
Part of the problem is it's probably a very heterogeneous group, like you pointed out. I mean, you can envision a 50-year-old who grew up, before inhaled steroids were around, severe eczema, sludged along, was in the hospital 8 times a year, and trust me, they were. That has an FEV1 of 43% now. They don't reverse very well. Then you have another 50-year-old who's a 3-pack-a-day smoker, maybe is a little atopic, maybe has sinus disease, they're a little reversible maybe too. But it's hard to believe that if you actually look, in other words, scope them and everything, that they're actually much different stories. So it sounds like there's 2 approaches, like, scoping everybody, or the kitchen sink and see who responded and why.
And the scoping, I mean, we talked about the sputum, induction and the scope evaluation. The more interesting is these patients, or subsets of these patients have varying, presentation through their clinical course. There are times when they're extremely eosinophilic, and then they become neutrophilic, followed by coming back to eosinophilic presentation. They're not always associated with the current status of their treatment. This is their clinical course itself, so which confuses the situation.
Yeah, that's
even
going to
more.
make life very difficult.
Yeah. Sometimes the more data, the more head scratching you have with these patients. So.
Thanks, Dr.